Good afternoon and welcome to the Royal College of Pathologists Guideline Implementation Webinar Programme. As ever, I'm delighted that we have a series of experts to introduce to you today the data set for the implementation of reporting carcinomas of nasopharynx and the oropharynx. My name is Peter Johnston. I'm the VP for Professionalism in the College, and as ever, it's a privilege to host these webinars. I'm also delighted to be able to introduce you to today's speakers. The lead author for this set of guidelines is Professor Keith Hunter, who will be talking to you, and co-authors Professor Tim Helliwell and Dr. Max Robinson. They've been responsible for writing the guidelines and will be here to address questions. Before we start, there's just a couple of points I'd like to bring to your attention. The first is that we will shortly be putting up a poll of 3 questions we would like you to answer as soon as you can. The purpose of this is to furnish some of the later discussion in this webinar. The talks, which will follow directly one after the other without breaks, will last altogether between 15 and 20 minutes, which will give us about 20 minutes for questions at the end. Please ask your questions through the Q&A function on your screen, and we will synthesize the questions as best we can to ask appropriately of the panel. You will be muted throughout, and so that is the way that we will have to address these questions. So without further ado, I would like to ask Professor Keith Hunter to start and introduce the session to us. Keith, thank you very much.
My name's Keith Hunter, so I'm going to do the second part of our presentation today, which is really addressing the issues within the new data set, particularly focusing upon the changes which we have made. I'm currently Professor of Head and Neck Pathology in the University of Liverpool, and I'm also a member of the Working Group on Cancer Services in the College, which oversees the data sets and the tissue pathway processes. So the starting point, as you can imagine, was the 2013 second edition of the dataset for reporting of mucosal malignancies of the pharynx, and had taken us really quite a long way to standardization of the reporting of mucosal malignancies in the pharynx. But we have, in the intervening time, which is now probably about 9 years or so, or perhaps even if you think a little longer for the evidence gathering for the 2013 dataset, maybe in excess of 10 years. So there were some developments to consider in the intervening time when we started to address the previous issue. That, of course, was we had the publication of TNM8 in the intervening time. The 2013 document was based upon TNM7. And I'm sure, as many of you are aware, the changes in TNM8 in relation to the head and neck group of tumours was really quite significant. These particularly related to some of the changes in the oral cavity, and also particularly in relation to the staging of the neck. Now, the changes in the neck are quite profound in relation to the cancers of the oropharynx in particular, but these are going to be the subject of a later dataset and webinar, which is currently in preparation. Other issues which have come to the fore in the intervening time are our use of ancillary tests in this anatomical region. These were mentioned to some extent in the 2013 version of the dataset, but we have now begun to understand a lot more of the nuance of the use and the limitations of some of our ancillary tests. And this is really quite an important change that's coming into the current version of the dataset. And Dr. Max Robinson is going to pick up on that in the last section of our webinar. Something which was not really on the horizon at all in 2013 was the whole area of immunotherapy. This is something which has obviously increased across a large number of cancer sites, with the authorization for use of pembrolizumab and various other immunotherapies available, particularly through clinical trials in the intervening time. This has become an issue which we have addressed to some extent within the dataset, particularly in relation to the companion biomarkers that are associated with immunotherapy. The last thing which was noted and was discussed to some extent in the 2013 classification was the issue of transoral laser surgery and transoral robotic surgery. This is something which has increased dramatically over the intervening period and brings with it a number of interesting challenges in relation to the specimens and how we assess the specimens. And so we have increased the amount of guidance which is present in the current dataset in relation to that. So in gathering the information for the dataset and these changes, we looked to the ICCR dataset. They had a comprehensive review of the literature and evidence base, which was much more recent than the 2013 College of Pathologists dataset, and so that was our starting point. The evidence was assessed by modified sign guidance, as in the College of Pathologists way of doing things. And one of the changes which we made, and this was really in keeping with the ICCR dataset, was to remove hypopharynx from an overall pharynx dataset, and that means that this dataset is solely related to cancers of the oropharynx and the nasopharynx. There was also, particularly in relation to the WHO classification in 2017, the integration of a separate category of HPV-associated oropharynx squamous cell carcinoma. And that has come with slight differences, as we will see in terms of TNM and so on. The testing recommendations, which Max will cover shortly, are something which have been evidence-based in the ICCR dataset, but we have decided, as we have on a number of occasions, to add some clarifications to that. And we did not feel that we were bound to go with every detail of the dataset, the ICCR dataset. We felt that if there was a compelling evidence for us to demur from that we should do so, and that we should clearly explain within the RC Path comments section in each of the data items what we were doing and the rationale for that. And the HPV testing recommendations are one particular example in that regard. And then there's also the TNM8 issues. And so we put together the writing team, as you can see in below. It's myself and Tim, Ann Sandison, and Max, and Gareth Thomas. So the core data items are not really going to be very surprising. The list of them is here. Not all of them are related to every part. For example, we know that in terms of histological tumor grade, that HPV-associated oropharyngeal squamous cell carcinoma is not graded. Elements related to the ancillary studies, we provided some extra notes in relation to that for our practice in the UK. And then there was the recommendation for the use of TNM8, although it has to be said that a number of ongoing clinical trials in the UK are still using TNM7, so there may well be occasions when you will revert to also giving the stage in terms of TNM7. The pattern of invasion was something which was removed, and we discussed this at some length. But as was noted in terms of the depth of invasion section, as you will see in the current and new dataset, the evidence related primarily to the oropharynx and to the nasopharynx was very limited indeed. And so we agreed with the ICCR decision to remove that as a core data item from the current dataset. One thing which we did not agree with was removal of bone invasion completely from the ICCR dataset. As we will see in a minute, bone invasion is a key part of staging in the nasopharynx, and so we felt that this should be re-added as a non-core data item. The PT assessment is shown in the slide here, and you can see the slight variations that we have in relation to oropharynx and nasopharynx. In oropharynx, the PT is still largely related to size, but there are also for T4, there are a list of structures into which the tumour is invading, with a greater granularity in oropharynx, HPV negative oropharynx cancer with T4A and B, whereas nasopharynx is PT1 to 4, largely in relation to the extent, the anatomical extent of the tumour. And as noted earlier, we're not looking at the changes in the N, the nodal assessment in TNM8. So that's all that I have to say, and I'm going to pass on now to Max to discuss in a little more detail some of the rationale behind the changes in recommendations for HPV-specific testing. Thanks, Max.
I'm Max Robinson. I'm a pathologist in Newcastle and have a particular interest in HPV and have supported clinical trials based on recruiting patients with HPV positive oropharyngeal squamous cell carcinoma. So I'm going to ask the question, What do we mean? How do we define HPV-associated HPV-associated oropharyngeal squamous cell carcinoma? So in the blue book, of course, it's referred to as HPV-positive oropharyngeal squamous cell carcinoma and HPV-negative. But then there's a bit of a disconnect between that and the staging manual that was produced by UICC and the 8th edition, suggesting that we can stage based on P16, using P16 positive and negative as the classifiers. So I'm going to ask the question, is P16 good enough for us in terms of making that diagnosis? And basically, P16 is highly sensitive, it's not always specific. For example, when you use this reference test here, which is the analytical gold standard, which is the detection of high-risk human papillomavirus E6 and E7 messenger RNA by reverse transcriptase PCR using frozen tissue. When you do that and then you compare it against P16, you get false positives and you get false negatives. So that means basically you're not sure when you've got P16 positivity whether it really is HPV driven. And in this particular study that was published in 2013 from Liverpool University, P16 had a sensitivity of 97%, which is great for sensitivity, but the specificity was 82%, which is less than ideal. P16 positivity is defined as moderate to intense nuclear and cytoplasmic staining in 70% or more of the malignant cells. And whilst this is an experiential empirical cutoff, which was defined by earlier studies coming out of North America, it basically it is an empirical cutoff, and isn't really supervised by any sort of biological analysis of HPV infection. Nevertheless, its clinical utility is very good, and the majority of our cases from the oropharynx can be classified into P16 positive and P16 negative. Occasionally, we get equivocal staining patterns, a bit like this. This one isn't nuclear and cytoplasmic, it's cytoplasmic. This one's nuclear. There's no cytoplasmic staining there, so that's an unusual staining pattern. And then these are, proportion staining. Is it nuclear and cytoplasmic, and what proportion of cells are staining? In these circumstances, it can be useful to have an HPV-specific tests to resolve issues around the classification. Is P16 good enough for prognostication? This is real-world data published in 2018 from a Dutch cohort of over 1,000 patients looking at oropharyngeal squamous cell carcinoma. This is the 5-year survival rate for the patients that they defined as HPV positive. That was P16 positive and HPV DNA positive by a PCR test. And you can see the outcome for these patients is very good. 80% of them, around 80% of them, survived the next 5 years. By contrast, those that were P16 negative and HPV negative, less than half of them survived 5 years. Interestingly, looking at this data, the green line represents those that are P16 positive but HPV DNA negative by the PCR test. And in these patients, they seem to track with the HPV negative patients. In fact, these patients only make up about 4% of this cohort, but that still equates to 48% of 48 patients in this study. Now that's Dutch data, and Holland's just across the water from us, and this is similar data from the UK, specifically from Liverpool and Northern Ireland. 100 patients show the same survival trends as the Dutch study. So the question is, basically, why is this important? Well, it's really important because if you take P16 as a classifier and try to enter them into a de-intensification of treatment as part of a clinical trial, then you may be selecting patients who are destined to have a poor prognosis anyway, and you're withholding effective treatment from them. And for example, in the PATHOS study, which is looking at post-operative adjuvant treatment and reducing the amount of adjuvant treatment they get, that trial is only recruiting patients that are double positive. Now, PATHOS is in phase 3 now and has gone international. And if that data is positive, then it's likely in the future that we're going to be using both of these tests to inform the provision of adjuvant treatment following surgery. I also think it's useful to have a HPV-specific test to inform the discussion with patients and their partners. When we talk about HPV-associated oropharyngeal squamous cell carcinoma, we're talking about an infection, a viral infection that many of the patients may have heard of in the past. And it's not a discussion around P16 positivity and the significance of that and the likelihood that it is driven by HPV. So I think that's a really important point for the clinicians in their discussions. So this is just my summary slide. P16 is an excellent but not perfect surrogate marker for oncogenic HPV infection. It is sufficient for staging in TNM8 and does provide adequate prognostic information. But I would argue P16 plus an HPV-specific test is specific for oncogenic HPV infection, supports the concept of precision medicine, which is the future, sufficient for staging. We get accurate prognostic information for our cohorts of patients. It is required for clinical trials, particularly in intensification treatments. And I predict it will become a predictive test in the future. It will inform epidemiological studies looking at HPV infection, not P16 positive cancer, HPV associated cancers. And I think it also facilitates effective patient communication. Thank you. That's the end of my presentation. I shall stop sharing and hand you back to the panel.
Thank you very much, gentlemen. Please come with your questions. We don't have any questions on screen yet. So while we're waiting for that, those were really interesting and practical questions, I think, that came to my mind, particularly, Max, was about, you showed us some pictures of what I guess you would call atypical or staining patterns that weren't as you would hope them to be. So you showed us some pictures of ones that had a proportion of cell staining and others that had nucleus and cytoplasmic staining. In terms of how do we, when we see that, how do we best regard these? What do we take out of them? What do you call positive and negative? I mean, it's easy enough just to record the staining pattern, but how do we help people interpret that?
Yeah, it's an excellent question, Peter. When we started off doing these sort of tests early on, there was very little by way of guidance as to how you would interpret these. And it's only by doing sort of testing to scale that you come across these sort of cases. And of course, then I'm sort of emailing people in the States saying, how do you record it when it's, it's nuclear staining only? What happens if it's just cytoplasmic staining, but it's, it's pretty intense, and it's more than 70% of the malignant cells. And then when we get this in and around the cutoff, then it becomes, the usual pathology issue around, what my 70% looks like compared to yours. And we have this in many areas. So I think for me, that has been the usefulness of having the ability to do an HPV-specific test, because if that HPV-specific test is negative, then I'm kind of sort of reassured that this is an unusual staining pattern, which is maybe a function of the tumor biology and the function of P16, which at the end of the day is an endogenous protein, which is involved in it's one of the cyclin-dependent kinase inhibitors, jamming the brakes on. It's trying to jam the brakes on, but it can't in HPV infected malignant cells. So I find that really useful in terms of trying to resolve the classification. And that's my argument for having a reflex HPV test. So the algorithm that we use is, if it's HPV, if it's P16 positive at that 70% strong nuclear and cytoplasmic positive threshold, then we test that for HPV and it's positive. And if it's not, it's we don't need to, if it's P16 negative, because it's so sensitive, we don't need to do an HPV test on that necessarily, because we don't really understand the biological relevance of having an HPV DNA in a tissue sample with no P16 elevated. So yeah, so I think that's the way I do it, Peter. You know, if I get an equivocal stain, then I'll do the HPV-ish on it and see what comes out of that. Otherwise, I record these as HPV as P16 negative if they don't hit that threshold. Thanks.
Yeah, thank you. Just on that, there's quite a few questions come in while we've been talking about this, and so someone's come in on the chat. Could you please use the Q&A function, because it's my small brain can't handle two chat lines at once. Just on the HPV P16 issue, the question: why are we still using P16 when we could use HPV testing with RT-PCR? Most places seem to have access to that. So why are we still bothering with the immunocytochemistry, I guess, would be the question.
Yeah, I'll take that question, Peter. So the study that I initially showed you was some frozen reserve specimens from the Liverpool Biobank, and really for reverse transcriptized PCR for messenger RNA, that's only really effective on frozen material. And you know, obviously, most pathology labs were dealing with specimens that were already prefixed. So we sort of we had access to that, and then we looked at the tests that had more clinical utility in an NHS pathology lab, and developed a testing strategy which we felt was sufficiently sensitive and specific. So that's the reason that we don't do that. The other thing is it's a grind and bind assay, so we don't get any feel for where the infection is. And these kind of studies that were done in the past were basically very confusing, actually. And this is why we've only kind of recently, sort of in the last decade, been able to start defining these things, because you can get you know, false positives from grind and bind assays that are highly sensitive, but are not biologically relevant. Thank you.
Yeah, thanks very much. And again, just on the issue, have you ever come across HPV positive cases that are P16 negative?
We have, yeah, very infrequently. So for the P16 positive HPV negative ones, we find in our sort of clinical trials and things that it's around about 5%. That's not very many. If we use our testing algorithm, which is if they're P16 negative, then you wouldn't test them. So that's one point. But in fact, we do test those HPV negative ones in our clinical practice as we started to develop an understanding of how the tests worked. And less than 1% came out as P16 negative, but HPV DNA positive. And the explanation for that is that, well, I don't know the exact explanation. My explanation for it would be it's either a transient infection that will get cleared, so you don't have any integrated virus, so it's just it's a passenger really, or you might be aware, or many of our participants might be aware, that P16 inactivation is a very, very common event in head and neck cancer. So it's possible that you've got P16 inactivation by mutation or deletion, or epigenetic silencing, and then you get your HPV infection after that. So that's our explanation. We're not because we haven't got enough cases. It's difficult to understand the biological relevance for the patient's progressive disease. Thanks.
Thank you. I think I'll maybe give you a wee bit of a break, Max, and change the subject slightly, because there's an interesting question which is about HPV vaccination. And do we think, or is there evidence that just as cervical cancer can be modified by HPV vaccination, could appropriate HPV vaccination modulate the effects of head and neck cancers? I don't know who wants to handle that one. Keith?
Yeah, I'll take that one. I think that's a very interesting question, and it was a very pertinent question about the time, particularly in the discussion of whether we should vaccinate boys or not. and whether there was enough data to actually support that. The data which is now coming through in terms of the prevention of cervical cancer is very encouraging. I think we see the efficacy of these vaccines, and it's now beginning to come through to some very significant reductions, and hopefully that will increase over the next while. But the problem was that there was no supporting data in relation to the incidence of oropharynx cancer. And we're probably still at too early a stage to really get any data, unless Max is aware of any data that has become aware. I'm not aware of anything which has shown that we're having any substantive effect on that as yet. So the effects are probably still to come. I'm hoping that it will be exactly the same, that we will have a similar effect, and that might mean that these HPV cancers are on a bit of a time-limited resource, but it's probably still going to see out my practicing career, I would imagine.
Yeah, thank you. It's the logic of vaccinating half the susceptible population has always been a questionable one, but there is no easy way to dictate vaccination strategies, as perhaps recent events have disclosed. Just some interesting stuff coming in on the chat, on the question and answer, really about people sharing their practice, which I'm not going to read out because it's there for everybody to see, but it's interesting to see what people are saying. You could pick that up if in the panel, if you wanted to do that. But specifically with regard to testing strategies, there is a question about, should we be routinely testing HPV DNA on all oropharyngeal cancers? I mean, I think in our place, we all do P16 on everything, but I don't know about the other. It's just, what do we recommend? Somebody's also suggesting we send everything to Newcastle. Whilst I think that, you know, the idea of we need a place to send stuff, I guess I would take the opportunity to say that the closer to the pathology department and the reporting lab the specialist testing is, the better, to tie it all together for maximum benefit to patients. But on that basis, what do we think about just let's test them all and see what happens? I'm sure that's done in studies, which probably explains why we don't do it all the time, but I'd like to hear that discussed, please.
Yeah, I can start that off, Peter. So the way that we've written the guidelines is basically, I think we're looking to kind of future-proof people's practice, you know. So when we first opened the clinical trials Compare and Pathos, which are two sort of started off as national trials, and sites were opened, we had about 26 sites open, and we dictated a central testing quality assurance for those trials that came to Newcastle. So all of them were tested with P16 high-risk HPV-ish, and as Pathos moved into phase 3, we basically decided that sites that were taking part could do their own HPV testing with a degree of a light touch quality assurance. So we've got sites now that are basically recruiting to Pathos, and they're doing their own HPV testing, and that's been facilitated by, you know, clinical trials picking up the bill for that. But that then comes into the laboratory, and hopefully that could be a legacy from the clinical trial participation. And we know that clinical, you know, getting involved in clinical trials are often sort of little bits that you get extra from taking part. So as we do that, I think the next stage for us is to kind of look at the landscape of what's going to change, and what I think is going to change is try to enable pathologists in the UK, by using the Royal College of Pathologists guidelines, to look at it and say, well, actually, you know, I think this is going to be a thing, and in our laboratory, I'd like to bring this in as a service improvement. And the justification would be that the authors of the data sets have highlighted this issue about, you know, why we should be doing HPV testing. I could sort of moderate that by saying, you know, many people might say the HPV testing and interpretation is not that easy. So P16 is dead easy, and I sometimes, try and persuade the laboratory staff to do it for me before I even see it. That's another service improvement. But yeah, I think, again, with the P16 16 interpretation, it's about being exposed to that, getting the experience, and the majority are pretty easy to read, and very satisfying in a way, So it certainly enriched my practice, and of course, receiving stuff from other units has opened up a dialogue in terms of, interpretation of difficult cases as well.
Yeah,
Thanks.
thank you. I think that's addressed the questions round about HPV testing. There's a delightful question in here, which is about etiology and pathogenesis, and no webinar would be complete without the challenge to the panel of such questions. So this one is around about the association between HPV positivity and the proportion of cancer stem cells in a head and neck squamous cell carcinomas. Do we know whether there is a relationship, and if so, what the significance of that might be?
Well, I can
definitely get a professor to answer that one.
I was looking in that direction, if you could see where I was headed.
It's interesting, we're still, to some extent, I think, in the dark in terms of the etiology of oropharynx cancer. There's been some really quite elegant and quite massive studies done looking at tonsillectomies and trying to see if we can find little early pre-cancer. And I know that Selvam Thavaraj has done some, and I think Max had a few cases where you could see something that was perhaps a little bit in situ. But actually getting back to the starting point of these cancers has actually been very difficult. I don't think we really know an awful lot about what is initiated, where it's being initiated, although generally we know that it's in the reticulated epithelium of the tonsil crypts, largely. So I think there's a lot to do in terms of working out what the actual initiating cell population is and what their stem cell status might be. So it's a very interesting question, but I don't have an answer to it, and I wonder whether either of my panelists have anything more to shed light to shed on that.
Well, thank
Peter.
you.
Peter, can I just point the participant to a? I'm just reading it here. I was just about to read it actually, and it's a. Hang on a second. It's a Nature Reviews Cancer publication, which I'll try and put in the chat. I'm not sure you do that, but it was by the authors are Matt Lechner, Liam Masterson. I think they have some association with Liverpool. I think Tim and Keith. I think, but that's a very long paper, and I'm sure they must talk about stem cells in there.
Sure they will if it's in Nature. Thank you very much. I'm afraid that we've kind of run out of time. Just want you to be aware that the recording of the webinar will be made available shortly on the college website, and it's there as a resource for members, so you can access them as you feel necessary, and also to allow your colleagues who've not been able to come to today's webinar to see the content of this webinar. So again, college website for that. It just leaves me to say thank you very much to the presenters, Keith, Max, and also to Ann Sandison and Gareth Thomas, who were involved in the production of the guidelines. It's also, I think, important to mention Maria Marrero-Feo, Cynthia Mitri, and Ganzi Sen and the College Clinical Effectiveness team, who have done and continue to do a lot of work to enable and facilitate events such as today. So thank you all for sharing your expertise. And thank you for participating. Thank you to everyone for turning out to join into the webinar. And I hope that you've had an interesting experience. We look forward to your feedback and have a good day. Thank you all very much.